So, allow me to introduce our first speaker. Our first speaker is from Japan. He graduated from the Showa University School of Medicine and is presently the director of Uji Tokushukai Medical Center. Let us welcome Dr. Yutaka Kobayashi, who will discuss to us the push-up technique and anatomical deployment for severely angulated aneurysm neck.
Thank you for inviting such a great conference, and I'm glad it is a great honor to be able to speak to you today. I'm going to talk about push-up techniques and anatomical deployment for severely angulated aneurysm necks. The push-up technique was reported by Dr. Dohi from Japan. It is a method of deployment against the severely angulated neck that utilizes the endurance device system. It is a push-up technique. The suprarenal stent is released daily to fix the proximal edge in place, so that the push-up technique is reported by Dr. Dohi from Japan. It is a method of deployment against the severely angulated neck that utilizes the endurance delivery system. In the push-up technique, the suprarenal stent is released daily to fix the proximal edge in place, so that the stent graft can be deployed and pushed up sequentially through the angulated neck without depressing the device upward. To begin, the main endurance device is inserted as usual, using a stiff wire. The endurance delivery system doesn't conform to an angulated neck, so it is inserted via the shortest route. The neck configuration straightens through the cis insertion in the case with mild angulated neck, but severely angulated such case, necks tend to retain their configurations. With the stent graft in position at the level of the renal arteries, rotate the external slider to deploy only one or the 1.5 of the proximal covered stent. Next, turn the back end wheel to initiate the release the top cap of the suprarenal stent. The stent is released very slowly, which make it possible to finally adjust the position of the proximal edge of the covered stent below the lower renal artery. Conclusion should be exercised because the suprarenal stent released suddenly after the exiting sleep. When the suprarenal stent is released, the external slider is rotated to resume deployment of the covered stent individually. It is important to push the delivery system up after each deployment to fold up the fabric between the stent. The concept of Dr. Dohi's technique is to prevent leaks by creating horizontal stripes by pushing the stent into the gap between the stent and the stent, which would cause a vertical fold if the stent left in place, leading to the leak. You can see the vertical fold. It causes leaks. It's a stent deploy and push up, and a stent deploy and push up. By repeating this, you can create horizontal stripes. And additional, also in severe angulation case, shortcut device can be pushed up to prevent the greater curvature side from floating. The first case presented in the case in which the push-up technique is not used. Endurance has good tracking performance for severely angulated neck even when used normally. Here is one case of EVA for ruptured abdominal aortic aneurysm. A 74-year-old male was taken to our hospital with temporary loss of consciousness and abdominal pain. His hemodynamics were unstable. In many cases of this ruptured case, the proximal neck is highly angulated by the giant aneurysm. This case also had a severely angled neck about 90 degrees, with a short proximal landing length of 8.8 mm, below which reverse tapering was observed. At first, performed atrial autography to implant the main device. The angulation was severe, but insertion of the device allowed neck to be straightened and placed in the right position without the use of push-up technique. Even in case where the push-up technique is not used, it is recommended that the proximal bear stent be deployed before the contralateral leg is deployed. Because the landing position of the edge of the covered stent can be accurately predicted by slowly deploying the proximal bear stent first. After the bilateral leg in the usual manner, final contrast confirmed that there were no leaks and the procedure was completed. Postoperative CT also shows that the endurance followed the angulated neck nicely, and no leakage was observed. The first proximal stent of endurance is 8 mm, and the proximal rounding of 8 mm is enough for EVA. And if the vessel is straightened in proximal neck with the step wire and the main device will follow the angulated neck without the need for special technique. The next case is a presentation of the patient using the push-up technique. A 93-year-old woman with severe angle of the proximal neck due to the giant abdominal aortic aneurysm. This case also had a flexion of the approximately 90 degrees. After stiff wire is inserted, the aorta is still severely angled. It was difficult to raise the main device. After the main device was inserted, the outer still angled. Push-up techniques are useful in such cases. After the orthography, as it is unsheathed, the device gradually follows the aortic curve. But this still leaves the device in the shortcut position. So the device can be pushed up to the press against the greater curvature side. In this state, slowly open the proximal bear stent. You can see the bulb. Once the bulb is visible, check its position with the renal artery and adjust the tension of the device. By pushing up before deploying the proximal bear, the greater curvature side is also raised and deploying more coaxially. Once the proximal bear stent is deployed, it is unlikely to get up proximally, so push up further to fill the gap between the stent and deploy to the leg. The push-up is only meaningful if it is done before the cysts fall into the aneurysm. No leakage is observed on the final contrast. Postoperative CT shows no leakage and the device follows severe angulated neck. The proximal part is sealed with 1 centimeter landing as originally planned. And the greater curvature side is pressed against the wall and followed as in the intraoperative contrast. Conclusions. The push-up technique and anatomical deployment using the endurance stent graft system is a simple procedure. The technique is effective in treating aneurysm with severely angulated neck, and many may have additional indications in the future. Thank you for your attention.
Thank you, Dr. Kobayashi. That was really a very interesting procedure. Any questions, Dr. Moon?
Yeah, can I? This is very. Thank you very much, Dr. Kobayashi, for your excellent technique that you've shown. Can you come back to the slide, the second case, the 93-year-old lady, because I think this is very important technique. If we can do what you, can we bring the slide back? ขอสไลด์คืนหน่อย yeah. When you bring, normally when if we don't do the push-up technique, when we bring the device down close to the left renal was supposed to be the lower renal, then we will miss the big gap on the right side. But you do the push-up before that deployment.
Yes.
Can you give a little bit more detail how you push and what did you do to push it against the greater curve?
Yes. I push up in this case before the suprarenal stent deployment because I aim the greater curvature side of the proximal stent of the covered stent is raised to the right renal artery. Then if suprarenal stent deployed fast, the proximal side of the stent graft is not coaxially. So I do the deployment push-up before deployment of the suprarenal stent.
Right. And then the access, do you do left or right side, is that important?
It's a left side access to the C cup.
The C curve.
Yeah.
So always do the C curve.
Yes.
We are familiar with the C and the S curve, right? So the C curve means that you access from the left side on this case.
Yes.
So you'll be able to push to the greater curve.
Yes. Push to the greater curvature side. Yeah, it's a need to access to the left side, in this case, the right C cup.
I see. And any issue about push and then they push everything up and cover the renals? Is that the problem that we can have?
Now, in the case of the straighten the angle insert the stiff wire and the main device, it is not to use the push-up technique because the device go up.
I see.
There. So in the case, we don't use the push-up technique.
Only the curve
Yeah.
we can do. Okay. Okay. Well, thank you. Thank you.
So any other questions from the audience? Yes, sir.
We'll get the microphone.
Thank you for your great presentation. I am Dr. Pirapat Kongmalai, cardiovascular and thoracic surgeon. I used to perform the push-up technique with the endurance device about 2 years ago. That case, the anatomy just like the second case of yours. During the procedure, I push up for the apposition of the stent to the angulated aorta. But after the final angiogram, it seems very good. But when I follow this case, I found that the patient has the increased aneurysm size progression very quickly, like about 10 millimeter in six months. So from the CT scan, the radiologist read that it's type 2 endoleak. So I go back and in my hospital we don't have the radial intervention, so I go back and open the aneurysm, just want to suture the type 2. But I found that it has active bleeding from the suture line of the stent graft. That I thought it maybe occur from the push-up technique, but I don't know that you have ever faced this problem. So in that case, I need to replace the aorta, replace the graft with the diaphragm graft.
Yeah, sorry. Please once more.
I found the type 4 endoleak from the stent graft. That I'm not sure that it is because of the push-up technique that we perform that it make the stent crack or it bleed from the suture lines of the stent with the graft.
So the suture lines bleeding, wondering that it may be from the push-up. Do you see the push-up cause any bleeding from the graft, or you?
The push-up technique cause the fracture of the stent graft?
Questionable. Is that possible?
No, I don't that experience.
Okay. Tanvira, you did that, and
Yeah, I do the similar technique and like similar the push-up technique. I think push-up when we have to push when I have to push the stent up, after I completely deploy the suprarenal fixation, and the push-up is not too aggressive, minimal push-up, not don't aggressive push-up, because I concern about the migration of aortic stent graft. I think don't don't correlate with the cause of a type of the endoleak or the suture. I think it's not correlation.
Yes, thank you.
Yeah, but if you do like Dr. Vira mentioned, do the push up after the suprarenal stent open, you did not do the first push up. Dr. Koye showed that we will miss that ceiling at the outer curve. I think that is different what we normally do here. Dr. Koye just showed that before you deploy the stent, you push it up against the outer wall, so we will gain more ceiling approximation at the outer curve, even better. I think this is very, very interesting technique, different from what we used to talk and we do it around here. So I think that very interesting, a very useful procedure, I guess. But after that, but everything does gentle, right? How slow do you push? How fast? Not how slow. How fast do you push the stent?
Yeah, I do this procedure to fast press up because I think the push-up technique is to prevent greater curvature side leak, but Dr. Dohi says that fold the stent graft and horizontal fold. But I didn't think that it's useful for the angulated neck to prevent the type 1 leak from the greater curvature side.
I think the push-up techniques make the better conformation after remove the delivery system or stiff Y because of the after remove the delivery, and maybe create a better conformation between aortic wall and the stent graft when compared with conventional techniques.
We have a question from the audience.
Okay, Dr. Kobayashi's very excellent techniques. I just want to know what are the very important steps, because of we're not deploying, we're pushing up. What are the very important steps that we have to really take precaution when we do these push-up methods, especially in terms of deployment of the stent? How many the maximum we can deploy before we can push up, or what are minimums so that get very good shielding in terms of outer curvature? So maybe your techniques.
Yes, I think the good trackability to the greater curvature side, it's to push up to the greater curvature side. But in the lesser curvature side, it's a fourth to the stent graft. It's originally to the Dr. Dohi's technique.
I have a question. What would guide you as to how many struts you push up when you're doing the procedure?
About one or two stents push up to the stent graft.
And you stop as soon as you pass the curvature? Is that a general rule?
Yes.
Any other questions? Yes, sir.
Thank you. Amazing presentation. We've tried to do these techniques several times by the push-up technique and reverse slider technique, different ways to try to overcome the angulated necks and things. Just wanted to share a few things. We've been seeing since morning, there are times where the stent is migrated down. There are times where, although not presented, there are several times where the stent might cover the lowest renal artery also when we try to push up. So one thing we have made a protocol is we always keep a wire in the lowest renal artery coming from the radial artery from above. We ensure that will cut down the usage of contrast because most of the patients are elderly with some form of deranged renal function. We keep a wire in the left lowest renal artery so that we know the position of the lowest renal artery, whether we are pushing up, we are doing the reverse slider techniques, or where the neck is very short. We ensure the lowest renal artery is wired and kept. There are several times that wire has been very essential for us where we might have to do a stenting of the renal artery where the devices got pushed up. So it is very essential, I think, to keep a wire in the lowest renal artery when we try to do these techniques.
Thank you for the comment.